Well, hello and welcome to everyone joining us for this X-Talks webinar. Today's talk is entitled Using Prognostic AI Models in Pathology, the case colorectal cancer. My name is Corey Stanton and I'll be your X-Talks host for this event. I'd like to thank Aiforia who developed the content for this presentation. Aiforia equips pathologists and scientists in clinical, preclinical, and academic labs with powerful deep learning AI and cloud-based technology. Aiforia's solutions strive to increase the speed, accuracy, and consistency of analyzing large and complex medical images, especially in pathology. Aiforia's mission is to transform pathology image analysis with AI, enabling better care for each patient. And now let's take a quick moment to meet our presenters. One of our speakers today is Dr. Rish K. Pai. Dr. Pai earned his MD PhD from Case Western University School of Medicine in Cleveland, Ohio. He completed his residency in anatomic pathology at the University of Chicago Medical Center, followed by a gastrointestinal and hepatic pathology fellowship at the same institution. Dr. Pai is currently professor of laboratory medicine and pathology and serves as director of the GI Liver Service and GI Liver Fellowship at the Mayo Clinic, Arizona. And joining Dr. Pai today is Thomas Westerling Bowie. Thomas is the CCO Americas at Aiforia. He received his PhD in cancer biology, focusing on cell cycle and transcription from the University of Helsinki Medical School in Finland. Thomas then completed a postdoctoral EMBO fellowship at the Dana-Farber Cancer Institute in Boston, researching the genomics of breast and prostate cancer. Recently, Thomas received an MBA from MIT Sloan School of Management, executive degree program. And now, without any further ado, I'd like to hand the mic over to Thomas to kick off the presentation.
Welcome everybody, and thank you for joining us for today's presentation. It's a really great pleasure for me to be the warm-up band for today's session. I'm going to do just a very quick intro before passing it over to Rish, who I've been working with for quite a while, and Rish is my favorite rockstar pathologist in the world. Let's see if I need to close out viewer here. Okay, there we go. So like Corey mentioned, so Aiforia Technologies we are trying to equip pathologists and researchers in various domains all around the world with powerful deep learning technology. We are a global organization. We're about 100 people, and we have a global reach, users all around the world. We are a publicly traded company, and some of our key customers include Mayo Clinic here in the US. What we do is we provide clinical solutions, we provide AI development tools, and research solutions. Some of the clinical solutions include the breast cancer suite, lung cancer suite, prostate cancer suite, etc. One of the things that we are really proud of doing is partnering with a lot of different organizations and researchers and ending up helping commercialization of AI tools. And Dr. Pai's colorectal cancer prognostic tool is one of those where Aiforia is commercializing that and selling it globally. Our breast cancer suite, as I mentioned, is used by Mayo Clinic, and if you're interested, please contact us on the contact form at the end of this, and we can share some more details. Obviously, we are very keen on quality and performance, and we are very grateful for the partnership by Cristina Del Rosario and Eric Chen from Mayo Clinic for doing this with us. The one thing that, while we are talking of a specific application today, I would like to point out and remind everybody that we can basically do anything that is from a 2D image. And if you can recognize things from an image, then we can actually can that and put that into a neural network and make you more consistent, or your organization more consistent and more powerful, more efficient. And since this is it's a cloud world and there's lots of security threats, this is something that we take very seriously. We are protecting your data in all situations. We have various ISO certifications for data security, quality management. We are also SOC 2 Type 2 and HIPAA certified.
Thanks, Tom, and thanks, Corey. It's a pleasure to speak to everyone today about some of the work I've been doing with Aiforia in colorectal cancer. And I just want to emphasize a little bit more about who I am. I am not an AI scientist or a computational pathologist. I'm a practicing surgical pathologist with specialty expertise in GI and liver pathology. So I really don't have a lot of deep expertise in neural networks, but maybe that's the beauty of Aiforia. Someone who is more of a pathologist with just a content, like to think about being a content expert and not being a computational person. And hopefully you can see some of the powerful things you can do with Aiforia with just having a content expertise. So being a GI pathologist, one of the most common specimens we get is colorectal cancer. And so this is why I focused on colorectal cancer, because it's a common cancer. And there's still a significant number of deaths per year from colorectal cancer. Young onset colorectal cancer is increasing for unknown reasons, so that's another reason to think about studying colorectal cancer in more depth. And pathologists play a critical role in prevention. We do a lot of surveillance colonoscopy evaluations, looking at polyps and things like that. And what I'm going to talk to you today about, though, is the role we play in the prognosis and management of colorectal cancer, and how AI can potentially be used to kind of augment our role. So before we jump into kind of the AI model, we kind of have to understand the question that I was trying to answer. And really, our pathologist role helps guide oncologic decision-making for stage 2 and stage 3 colorectal cancer. So I'll give a little bit of understanding of what stage 2 and stage 3 means. Stage 2 is deeply invasive colon cancer, but it hasn't spread to lymph nodes. Stage 3 is when the tumor has spread to lymph nodes, but not distant metastasis. So these are kind of the key stages in which the oncologists rely on the pathology report to figure out what to do. Stage 1 and stage 4 are sort of different, and we won't talk about that. So we'll focus mainly on these localized stage 2 and spread to lymph node stage 3 colon cancers, and try to understand how pathology and how AI can be used to help guide oncologic decision making. One of the things that is a little bit of a challenge, though, is the decision to give chemotherapy or not in stage 2 and stage 3 are based on pathologic features that are diagnostic challenging. So features that maybe a pathologist disagree with one another on. And so that's an important area where maybe AI can help kind of standardize things and maybe provide more information and more reliable information to help guide therapy. So that's kind of the theme of this talk. But I'm going to jump into kind of the features that we currently use now to guide therapy, to give you a sense of how it's done now, and then how AI can potentially be used to kind of help in the future. So this is the guidelines from the American Society of Clinical Oncology, published in 2022 on stage 2 colon cancer. So again, deeply invasive cancer, but it hasn't spread to lymph nodes. Basically, there's not a lot of patients that end up getting adjuvant chemotherapy, and the patients need to be in a high-risk subgroup in order to be considered for adjuvant chemotherapy. So what does that mean? What are some of the bullet points from this? Well, patients with mismatch repair deficiency, which is an alteration that is present in around 15% of colon cancer, those should not be received adjuvant chemotherapy. So we can just remove that subset from oncologic adjuvant chemotherapy. And so that's pretty straightforward. These other things, though, are where pathology gets involved. So patients that are tumors that are deeply invasive all the way to the serosa of the colon are at a higher risk of recurrence, and those patients should be offered adjuvant chemotherapy. And that's kind of the strongest recommendation from ASCO here. And then there's a whole other group of tumors where if there's a high risk factor, like the tumors surrounding nerves or in vessels, or it's undifferentiated, or it has this thing called high tumor budding, which we'll talk about, those patients may be offered adjuvant chemotherapy. So we have a big group that should not be offered. T4 tumors should be offered, and then this subgroup that may be offered. So we actually have kind of 3 groups when you think about it. We have low risk stage 2, which are this microsatellite deficient subgroup, and then subgroup that doesn't have any high risk features. Those patients do not get any chemotherapy. Then we have this intermediate risk group, which is based on these pathologic features that can be challenging, like is it in a vessel, is it in a nerve, is there high tumor budding, are the margins close, did we not recover enough lymph nodes? Those may be offered adjuvant chemotherapy, so you can consider this as being kind of an intermediate risk group. They have a higher risk of recurrence, and so you give chemotherapy to reduce that risk of recurrence. And then you have the highest risk group of patients where the tumors are at the serosal surface, and those should be offered adjuvant chemotherapy. So we have this low risk, intermediate risk, and high risk. And when you kind of analyze and put tumors into these groups, and then ask the question, well, do they predict recurrence-free survival? And you can see, yes, they kind of do. The high risk group in red here has a higher risk of recurrence compared to the low risk group here, which is in blue, and the intermediate risk group is in the middle. So the ASCO risk scheme kind of does do its job. It risk stratifies patients based on risk of recurrence, and then that information is then used by oncologists to decide if they want to give chemotherapy or not. And again, these should be getting chemotherapy. These may be getting offered chemotherapy, and the blue is no chemotherapy. But one thing is, if you remove the MMR deficient subgroup, what happens is the ASCO risk scheme for the other MMR proficient subgroup of tumors doesn't really work all that well. The Kaplan-Meier curves kind of collapse. So that's what we're going to be focusing on here. And one of the issues that comes up with how oncologists use our information to guide chemotherapy is that we're quite variable in how we report tumor budding, and how we report venous, lymphatic, or peritoneal invasion, how we report depth of invasion here. These are just, this is real world data from 3 centers, and you can see that the variability among the different centers in these high risk features is quite striking. You can see that center 1 here only called venous, lymphatic, peritoneal invasion in around 18%, where center 3 called it in 62%. And center 2 was around 45%. So if oncologists are using this feature to determine adjuvant chemotherapy, you can imagine that the results will be quite different in these different centers. And so this to me made using AI to kind of help this decision making kind of an attractive research project. And just to give you a little bit of a background about how variable we are in reporting this feature. This is one study just looking at that T4 issue, which is tumor touching the serosal surface or invading another organ. The T4A is when the tumor is touching the serosal surface. That's the pathologic designation for that. And this is just a study from the Netherlands showing significant variability in rates of T4A across 33 different labs. And you can see the different rates of T4 reporting. And again, if oncologists are using this data, this piece of information to guide adjuvant chemotherapy, yet there's so much variability across these various labs, you can imagine that's maybe not the best, and maybe we need to optimize the decision tree a little bit better. Because I'm a pathologist, I have to show some pathology pictures. These are some of the issues, and we don't need to go into detail, but if the tumor is close to the serosal surface with some serosal reaction, that is a diagnostic challenge for pathologists. That's where this inter-observer variability comes in. That's where we're not sure if it's T4A versus T3, and if that decision is going to be used to guide adjuvant chemotherapy, again, that's where these issues come up. And there's a lot of other features that could be important for recurrence, risk of recurrence. This is just T4 and T3, as I mentioned. T4 is supposed to be a higher risk, but in real world data, sometimes T4 actually isn't the most important feature. And there are other features like venous invasion and tumor budding, which is this morphologic correlate of epithelial mesenchymal transition at the leading edge of the tumor. These tumor cells, these little small foci of tumor cells that I'm showing you here with my mouse, these are the highly metastatic cells, the cells that end up spreading to lymph nodes. So we can actually measure tumor budding in the microscope, and that information is actually powerfully prognostic. And so maybe oncologists should be focusing on some of these other features, and maybe AI can be used to help guide this. So that's kind of what we're leading up to. And not to go into too much detail about tumor budding, but the reason why I want to talk about it, because it ends up being pretty important in my AI model, is that in this Japanese study of stage 2 colon cancer, tumor budding, the number of tumor buds in a tumor really predicted relapse. And you can see that if there was low budding, the patients did quite well. If there's really high budding, the patients did quite poorly. And in fact, tumor budding, based on the concordance index, which we don't need to go into too much detail, was actually the most important feature in this cohort of patients. And the second most important was that T4, T3 distinction. So again, tumor budding may be an important feature, and maybe that should be emphasized more in the clinical decision making. And that's kind of where AI can kind of help integrate a lot of these histologic features together to come up with a prognostic score. So just some take-home points about what we currently do. Reporting high-risk features in tumors is quite variable. Supporting T4 is currently the most important feature used by oncologists now, but these other features may have more prognostic impact. Let's jump into stage 3 tumors, and then we'll jump into my AI model. So stage 3, the clinical decision for oncologists is not if they're going to give chemotherapy, but how long they're going to give chemotherapy. Is it going to be 6 months or 3 months? And they use pathologic features. Again, they use T4 as a feature for giving higher length chemotherapy. And they use the number of lymph nodes that are positive to also give a higher duration of 6 months of chemotherapy. So T4 or N2 is where there's 4 or more lymph nodes positive. If they're T1, T2, or T3, or N1, they get 3 months of chemotherapy. So it's really a dichotomous choice based on these features that help determine length of chemotherapy. And so there's low risk stage 3 and high risk stage 3. High risk gets 6 months, low risk gets 3 months. And when you look at how the ASCO risk scheme performs in stage 3 in real world data, this actually looks pretty decent. Low risk has a lower risk of recurrence, high risk has a higher risk of recurrence. These would get 6 months of chemotherapy. These patients would get 3 months of chemotherapy. But still, this relies on pathologic features like T4, and we understand that that's quite variable. And this is a little bit more of a simplistic scheme, and there's a lot of other features that potentially could help determine risk of recurrence that we're losing by just focusing on these 2 features. So again, could AI help this decision tree? And so when you step back a little bit and you look at everything that we've learned about colon cancer, and then we look at how the oncologists use our pathologic data, there's certain features that they focus on, and there's certain features that pathologists believe are more important that aren't really used by oncologists. So we actually have quite a lot of features that have been studied, and some of them most of them are prognostic, and we understand their importance, but they're not really used in this decision tree that I've showed you that oncologists use. And in fact, there's actually too many features. So how would oncologists interpret the presence of one of these features as being, a poor prognostic sign, whereas others being not a poor prognostic? How do they interpret it? So if there's a way to integrate a lot of these features into one kind of prognostic model, that could be more powerful. And this is a perfect example of where I think AI can be useful. And of course, there's been a lot of studies looking at AI in colon cancer. I'm just showing you a few. This was the study that we published a few years back, and we're going to talk about this. And I took an approach that was very time intensive for a pathologist, but it ended up being highly rewarding for a pathologist, because it confirmed that what we understand about colon cancer is true. It's just quantifying those features are difficult, and AI is a perfect way to quantify things better. And we'll do some deep dive into this study. So when you think about how AI can be used in really broad strokes, and again, I'm not an AI, I'm not a computational scientist, but this is just kind of my understanding. There's hypothesis number 1, where the information on the recurrence and the risk of recurrence in colon cancer is within the glass image, but we don't really predefine what those features are. We just want AI to figure it out for us. And I call this a little bit a black box AI. It's not quite such a black box anymore. You can kind of look under the hood, but basically you're telling the neural networks something in this slide is going to predict badness or recurrence, and I don't know what it is. Figure it out. And that's kind of the approach that a lot of computational scientists make, because you don't need pathologists here. You just need the slide, and you need a set where you know the outcome is good and the set where you know the outcome is bad, and train a neural network to figure out what's bad and what's good. The other hypothesis is we know a lot about colon cancer already. And it's just the quantifying of those features that is challenging. And so the assumption is we already know what drives prognosis, and measuring the features is a problem. And I call this kind of interpretable AI. We kind of are just using AI to help quantify things a little bit better. And this is the approach I used. This requires highly supervised training. It requires manual annotations. It requires predefining the features you want to look for, and then training neural networks to identify those features. And another thing that is useful when you do this interpretable or this quantitative AI is that it can be used for multiple purposes. I use it to predict recurrence, but in the future you can imagine that extracting data that I'll go into can be used to say, well, will this respond to certain chemotherapy, or will it respond to something else? Or you can use it for multiple things. So you need pathologists here, but the output you get from it can have multiple uses down the road. Okay, so we'll jump into sort of the AI model that I developed, and this is called QuantCRC using the Aiforia platform. This is the information on the training cohort for building the model, the QuantCRC model. It ended up being around 560 tumors. You can see the tumor stages here. There were 24,000 annotations from over 5,200 training regions. Importantly, the H&Es, the hematoxylin and eosin-stained slides, were from multiple labs. That's important. There was a lot of variability, which is good because that's real world. That's what you want the model to perform on. It performs on from H&Es from multiple labs. They were scanned at 2 magnifications, 40x and 20x, on the Leica Perio GT450 and AT2. So the scanner types are also important. And then these are the features I predefined. So you have to, in this model, I predefined what I wanted it to learn. I wanted it to learn tumor grade. Is it high grade, low grade, and also signet ring cell cancer, which is a specific morphology of colon cancer. I wanted to identify mucin and quantitate that. I wanted it to quantify necrosis. I wanted it to look at tumor budding, these small tumor cells at the leading edge or actually within the tumor bed. And these are the cells that are undergoing epithelial mesenchymal transition that are the most invasive and that will likely spread. And we know that from multiple studies. Poorly differentiated clusters are kind of big brothers to tumor budding, but they're the same process, but just a little bit bigger, these kind of clusters of tumor cells. So I wanted it to identify those. And then I understood and from the literature that the type of stroma that's associated with the cancer is important. Is it this immature stroma that's kind of the cellular spindle stroma? Is it immune-rich stroma or inflammatory stroma? Or is it really rich in collagen? And so I wanted it to recognize the stromal subtypes. And I wanted it to also identify tumor-infiltrating lymphocytes as objects within the epithelium of the tumor. So these are kind of the features that I predefined, and I manually annotated. 2 of us manually annotated, so 24,000 annotations. And we trained the neural network to identify these features in kind of a sequential manner in different layers. And that layer structure is actually quite useful. So layer 1 identifies these features: carcinoma, stroma, tumor budding, and poorly differentiated clusters as one feature, necrosis, mucin, smooth muscle, and fat. Layer 2 takes the stroma from layer 1 and then further subdivides it into these 3 subtypes. Layer 3 takes the carcinoma from layer 1 and then further divides it into high grade, low grade, and signet ring cancer. Layer 4 identifies tumor infiltrating lymphocytes within the epithelium of the tumor, which is the carcinoma and tumor budding layers. So that's kind of how the model works. So again, you manually annotate, you train convolutional neural networks for each layer, and you get this beautiful color output, which is quite visually pleasing for a pathologist. Just to give you some examples of how this looks, this is an area where there's a lot of tumor budding. I can see that. This is an area where there's a lot of mucin. This is the output from the AI model. Red is tumor budding, blue is mucin, and I think it identifies them pretty well. These are tumor infiltrating lymphocytes. These structures are these cells here are the TILs. This is immature stroma. This is immune-rich stroma. You can see the AI model identifies the TILs quite nicely, the immature stroma and the inflammatory stroma. So putting this all together, you have a section of tumor, you circle the tumor bed, which takes around 2 seconds for a pathologist to just outline the tumor bed, and you hit run, and you get a lot of information. And I ended up extracting 15 features from this data. And these are the features that comprise QuantCRC. So we'll run through them real quick. It's it's simple stuff like percent tumor, percent stroma, the tumor-stroma ratio, the percent tumor budding within the epithelial compartment, percent mucin within the tumor, percent necrosis, percent high grade, percent signet ring cancer, the different stromal subtypes measured as a percentage of tumor bed and also measured as a percentage of stromal area. And these are different measurements and they provide different information. And then the number of tumor infiltrating lymphocytes normalized to the epithelium of the tumor. And so these 15 features are kind of, you can use them for anything you want. And there's even more data we can extract from this model for future discovery as well. And so I had these 560 cases. I used it to build that model. And then I reserved a whole bunch of cases for this validation and also to build a prognostic model. And so all in all, I think I've analyzed over 8,000 images, so probably way more than 8,000 now. But this is sort of an older slide just showing you the different cohorts that I then applied this model to. And importantly, we had, and I built a prognostic model using tumors that I knew their recurrent status. Did they recur? Did they have a metastasis and recurred, or did they not? And so I can kind of now build a prognostic model with the QuantCRC data that I'm generating. And so I'll run through some data that kind of correlates the model with pathology, and then we'll talk about the prognostic model and how it can be used. So we had these around 7,000 cancers at the time of the publication that I could use to test for associations with the model and how the pathologist would interpret the case and any underlying molecular features that we had. And then I used this to build and validate a prognostic model, the recurrence data cases. So we know that the colon cancer, this mismatch repair proficient and deficient division has a lot of morphologic correlates. MMR deficient tumors look very different under the microscope. And lo and behold, the QuantCRC data, I'm just showing you a few of them, did identify differences between MMR deficient and proficient tumors in terms of tumor stroma ratio and a whole bunch of things. Most importantly, tumor infiltrating lymphocytes. We know that TILs are more common in MMR deficient tumors, and lo and behold, the AI model did identify a lot more TILs in MMR deficient tumors compared to proficient tumors. KRAS and BRAF mutations are also very, have a distinctive morphology. It's actually quite subtle under the microscope, but the AI model was able to identify these subtle differences, which was quite interesting. And just more molecular data and how the AI and molecular, you can kind of use AI to sort of interrogate the molecular alterations within the tumor, which was kind of interesting. Don't need to go into too much detail, but we looked at KRAS BRAF, we looked at CpG methylation, which is another event that happens in colon cancer. And again, we saw a lot of associations between the molecular alteration and the AI output. How did the algorithm perform with pathologist manual review? So we had around 645 tumors where we had the pathologist tumor budding grade, and we grade the tumors and the budding into grade 1, grade 2, grade 3, and lo and behold, when pathologists graded the tumor as high grade tumor budding, the percent tumor budding by the algorithm increased, and this was really nice to see. We also had some immunohistochemical data on this. We had CD8 T cell immunohistochemistry data, so we could correlate the immunohistochemistry to the TIL data and the inflammatory stroma data that we can get from the AI model. And you can see when the tumors were CD8 high, the number of TILs was higher, and the number of immune cells within the stroma was higher. So now we're using this to build a prognostic model. So we applied the AI model to those 7,000 cases. We analyzed how the AI model correlates with the molecular alterations in the tumor, how it correlates with the pathology interpretation. But what I really wanted to do, and what was most exciting, was can we use these AI features and figure out which tumors are going to recur and to maybe help guide adjuvant chemotherapy. And to do that, I divided my cohort that I knew the recurrence data about into two cohorts. This training cohort, so this is again separate from the 560 cases that I used to train the model. These are the models never, the AI model QuantCRC has never seen this in terms of you know, the Aiforia model. I'm applying it to these 2,411, extracting the QuantCRC data and then using that data to understand what features predict recurrence. So this is building the prognostic model using these 2,411 cases from the colon cancer family registry, which is a long-running cohort. It's been funded by the NIH for over 20 years. I'm currently the Mayo PI, so I had access to this. And then once I build the prognostic model, I reserve 1,374 for this external validation. Did the prognostic model that we learned, that we trained on the colon cancer family registry data, did it work in the external cohort? So it ends up you need a lot of models. I mean, you need a lot of cases to kind of do this, and that actually ended up being the most challenging part. Building the model was actually not the most challenging. Collecting the data sets to validate the model was more challenging. So this is kind of how the training worked. So I take those 2,411 cases, apply QuantCRC, get the data, get those 15 features, combine that with mismatch repair status and overall stage, because we know these are important, and then train a prognostic model to figure out which tumors are going to recur at a higher rate than others. We use lasso regression. The prognostic model provides a probability of recurrence-free survival at 3 years, which is really a kind of a nice data point to get. And we measure the model performance in the external validation set using the concordance index. And this basically is a number from 0 to 1. 1 is a perfect model. 0.5 is a random model. Anything above 0.7 is considered good. So again, this model provides the 36-month recurrence-free survival estimate, and that's a number that is a continuous variable. And so to make it a little bit more useful for oncologists, it's kind of going back to their model of how they think about tumors: low risk, intermediate risk, and high risk. So I kind of use this 36 months predicted recurrence to divide tumors into low, intermediate risk, and high based on the 33rd and 66th percentiles in the training cohort. So again, I use the training cohort to develop this model, and then use the training cohort to define the cutoffs for low risk, intermediate risk, and high risk for both stage 2 and stage 3 tumors based on the 33rd and 66th percentiles. And so now when you think about the model, you apply it to a tumor, you get a 36-month probability of recurrence-free survival. You use that number, which is a continuous number. You apply these cutoffs. For example, in stage 2, if it's above 0.915, it becomes a low risk. If it's below 0.86, it becomes high risk, and all the other values are intermediate risk. So I can now place tumors into these risk categories, which can be useful for oncologic decision making. This is the same thing for stage 3. I trained the model using that colon cancer family registry data, and then use that same data to define the percentiles for low risk, intermediate risk, and high risk for stage 3, and these are the cutoff values. So now I take all that model training that we did and apply it to the external cohort. So the model, again, provides the 36-month recurrence-free survival. I have the cutoffs defined by this cohort as well, and I apply those same cutoffs to now this external cohort and see how the model performed. Did the concordant index, was it a good concordance index? Did the risk groups that these tumors are placed into have differences in terms of recurrence? Did it actually predict tumors that were going to recur versus tumors that had a low risk of recurrence? So I took these external validation cases, applied QuantCRC, got the stage and MMR status, fed that into the model. It spat out the 36-month recurrence. And then I can define risk groups. If it's stage 2, low risk, intermediate risk, and high based on those cutoffs I knew, I predefined, and stage 3 risk groups. And you can place tumors into the risk groups using this model that only includes QuantCRC, TNM stage, and MMR status. So it's really a simple model that only includes these 3. I mean, the QuantCRC has 15 variables, but you can think about it as like the AI features. And then you can identify these really powerful risk groups. So you can see low risk is truly has a low risk of recurrence, high risk stage 2 had a high risk of recurrence. And again, this is in the external validation set. And again, low risk stage 3 and high risk stage 3, really, really powerful in terms of separating out tumors with a low risk of recurrence versus a high risk of recurrence. And the concordance index was 0.75, which is quite good. So this QuantCRC model now can provide this kind of risk grouping. How do we incorporate that in what oncologists are currently doing now? And so this is kind of the next step in this model. Like, sure, it provides a low risk, intermediate, and high risk for stage 2 and stage 3, but we already have low risk, intermediate risk, and high risk based on pathologic features. Is there a way to integrate AI into what we are currently doing? And that's what the next step in this model development, and that's what I'm doing now, is I'm trying to incorporate the AI output into what the oncologists are already using, and maybe combining the two together can provide even more powerful prediction of recurrence. So how do I do that? Well, I took that external validation cohort. I kind of applied the ASCO risk scheme to that, because ASCO has its own risk scheme, and then incorporated the AI model kind of on top of that, and just including some features in the ASCO model, and then combining with the AI features. So just to go into this, what I did was take these stage 2 MMR proficient tumors, which are the really difficult ones for the oncologist, applied the model, got low risk, intermediate risk, and high risk from my QuantCRC model, and then used this data to combine it with the ASCO risk scheme. So we're almost at the home stretch here. So just want to illustrate, this is what the ASCO risk scheme by itself looks like in this cohort of stage 2 MMR proficient tumors. It identifies 61 high risk, 168 low risk, and the rest in the middle. The AI combined with ASCO, what I call the QuantCRC integrated risk scheme, takes the QuantCRC low risk, intermediate risk, and high risk, and just takes T4 and T3 from the ASCO scheme and identifies a different and risk stratifies in a different way. And so I thought maybe this model can outperform the ASCO scheme and really provide a better tool for oncologists to risk stratify tumors. And lo and behold, there was quite a significant difference in how the AI integrated scheme versus the ASCO scheme risk stratified tumors, and just showing you there was the kappa in terms of agreement in these schemes was only 0.25. So the QuantCRC scheme is doing something quite different than the ASCO scheme. So the question is, does it do a better job? And the answer is yes, it does. So this is the ASCO scheme. You can see the Kaplan-Meier curves are quite compressed between these integrated, between these risk groups. The AI integrated, or QuantCRC integrated, really provides more robust separation between low risk, intermediate risk, and high risk. And this was true whether looking at cases that did not receive in the ASCO scheme that no adjuvant chemotherapy, you can see the Kaplan-Meier curves are quite compressed. In the QuantCRC integrated risk scheme with no adjuvant chemotherapy, you're identifying the tumors with different risk much more robustly, and you can see the hazard ratios and p-values. So the QuantCRC integrated scheme really provides a robust separation between lower, intermediate risk, and high that outperforms the ASCO scheme. And you can get actually estimates well, sorry, let me step back a little bit. This is looking at some clinical data that kind of correlates with recurrence. CEA is a biomarker of tumors, colon cancer. And you can see in the QuantCRC integrated scheme, the high risk tumors actually had a higher proportion of elevated CEA, which oncologists know is a marker for aggressiveness. So this correlates better than the ASCO scheme, which the different risk groups didn't actually have any differences in elevated CEA. So that was kind of interesting. And I just want to highlight that using the QuantCRC integrated risk scheme would actually change how the oncologists would give adjuvant chemotherapy. Only 1 out of the 31 intermediate risk QuantCRC group that were classified as low risk in the ASCO scheme received chemo. So potentially the ASCO scheme versus the QuantCRC integrated scheme would actually change who would get chemo versus not, and potentially improve administration of chemo to those that would most benefit from it. And you can get probabilities of recurrence at 3 years in the QuantCRC integrated scheme that are quite different and more spread out than the ASCO scheme. Basically, we're truly identifying patients that have different risk of recurrence. In the next 5 minutes, I'll talk about how we integrated AI into the ASCO stage 3 model. And this is the cohort of stage 3 cases we used. There's 518 here. These are kind of how the AI features can separate out different risk groups. And this is kind of the raw data. And then I applied the QuantCRC model and the prognostic model and got these risk groups from the QuantCRC data and incorporated the risk groups into the ASCO risk scheme by just kind of layering the AI risk groups on top of what the ASCO is already doing. And it kind of regroups tumors into low risk, intermediate risk, and high risk versus the ASCO scheme, which has a very simple low versus high risk grouping. And again, I asked the question, does the AI integrated scheme outperform the ASCO scheme? And you can look at the Kaplan-Meier curves and you can see that the ASCO scheme, of course, does identify this high-risk group that has a higher risk of recurrence, but the QuantCRC integrated risk scheme actually identifies an even higher risk group that has a very high risk of recurrence and actually separates out this intermediate risk group with a lower risk of recurrence. And it's probably these set of tumors that deserve the 6 months of chemotherapy versus these set of tumors, which may only need 3 months of chemotherapy. And so you can reduce the number of patients getting this extended chemotherapy significantly, and only 80 or a smaller proportion in the QuantCRC integrated risk scheme would need to get chemotherapy. These are the recurrence estimates using the ASCO scheme and the QuantCRC integrated scheme, and you can see the rates of recurrence are more spread out in the QuantCRC integrated risk scheme, that we're truly identifying tumors with different risks of recurrence. And this is some data showing that both the integrated low risk and intermediate risk tumors may only need 3 months of chemotherapy, because adding 6 months of chemotherapy to this group didn't really improve their survival. So maybe only those high risk tumors identified in the QuantCRC integrated scheme deserve the more extensive chemotherapy. So just some take-home points. I went through some of this data quite quickly, but you can see how I started with a clinical question about how oncologists use pathologic data to guide adjuvant chemotherapy, and understood that, hey, there's a need here, and maybe AI can be useful. And so taking a quantitative approach, identifying these 15 features, using that to build a prognostic model, incorporating that prognostic model into the ASCO scheme, and seeing if it can improve risk stratification to better guide adjuvant chemotherapy is kind of the path I took. And hopefully I demonstrated that this AI integrated scheme, this AI model, combined with some of these other features that we already know are important, can be even more powerful and kind of better risk stratify tumors and better help guide oncologists to determine, do they need chemotherapy, or do they need a longer chemotherapy regimen versus a shorter. And another thing that's useful is these 15 features, although I use them to build a prognostic model, it can be used for multiple tasks. So in the future, if new therapies come up, we can use these same features to see if certain features predict response to chemotherapy, which is also very exciting. So I'll stop here. I think this leaves around 12, 13 minutes for questions. And just want to thank everyone for paying attention and for listening.
Well, excellent. Thank you very much for that insightful presentation, Dr. Pai, and welcome back, Thomas, to the screen. As Dr. Pai was saying, we are now ready to begin the Q&A portion of the event. And as we do so, I invite the audience to continue sending their questions or comments using the questions window chat box. We already have received quite a few here, which is great, and please feel free to keep sending them as we work through our Q&A. I will go ahead and start with the first that we've received. This audience member was asking about which communication protocols does the suite support, for instance, HL7, FHIR, etc. Maybe you guys can expand upon that.
Yeah, maybe that's for me. So we support all of those, and so our primary is RESTful API. That's usually how we drive the integration, but we are very agnostic to third parties. So whatever it is that you have, that's what we integrate to, and we support all the modern communication protocols.
Great, excellent. I think this a couple more here are probably for you, Thomas. Here, this question here from the audience is asking about the annotations classes of the QuantCRC training data set. You know, how many annotations per class were used to train the model, and then maybe expanding upon that, which neural network did you end up choosing for the model?
I guess that the number of annotations or per class, that's for Rish. The neural network choice. So we have made the platform relatively simple and easy so that you don't need to choose. We are constantly updating and changing. We are using both proprietary and open source solutions. And so you can choose depth and width of the neural network, but it's all convolutional neural networks that run on the AI image identification. It's relatively simple, at least from my perspective, to use, and we are trying to remove. You don't need to understand about UNets or anything else like that. We are optimizing the platform quite heavily so that it actually gives the most bang for bucks. I don't know, Rish, did you have any, kind of trouble in like what to choose, how to choose? Maybe your input here is more important than mine.
Yeah, the annotations per class it's a good question, and it depends. And I have the numbers somewhere in my because the reviewers asked that, of course, for the publications, and I have it. But it's really the number of annotations needed are dependent on how good the model performs. So it's an iterative process. You don't just annotate a bunch and then hit run and then you stop. The way that I built this was annotate a little bit to see how it looks from a visual perspective, annotate some more, and then when I was satisfied for it by the feature, that's when I brought in external pathologists who've never seen the model. They annotated, and then the AI model compared to their annotations was used, so we can develop kind of their sensitivity and specificity for each feature. I also had external group of pathologists do a global assessment of how they felt the model performed. Did it make severe errors? Did it make minor errors? Did it make kind of moderate errors? And so I validated each class by external GI pathologists who are experts in the field in multiple different ways. And so the number of annotations were really dependent on some features are really easy to identify. Mucin, for example, was not a big deal because mucin looks very similar across the tumor sets. But other features were more challenging. Tumor budding was a lot. Tumor infiltrating lymphocytes, to separate that from apoptotic debris or neutrophils and stuff was quite challenging. The different stromal subtypes was actually relatively easy. So different classes, I felt the neural network was able to recognize different, a little bit easier than others. But this iterative approach of annotating, training it, seeing how it looks, annotating more, training it, seeing how it looks is really the way to go. And then, of course, once you're satisfied, taking it to external pathologists who can rip it to shreds or not, depending on how it performs, is really also important. And there's data on that in the publications as well.
Yeah, so all of this is published. So if you send the contact page for more information, we'll be sure to provide you with links to those so that you don't have to go and Google for an hour to find them. But I think all of them are. You're the last author, right, Rish?
Yeah.
So should be easy to find, but we can provide them for you.
Okay, great, excellent. Yeah, thank you for that. A few more questions from the audience. I think it's possible you may have answered some of them, but I'll go ahead and ask through anyway. Back on the topic of the neural network, this audience member was wondering, was the neural network, is it trained from tiles? And if yes, could you talk about how you achieved to generate specific output from square tiles?
Well, so we are not strictly using tiles, so there's a little bit of proprietary magic sauce that I won't go into too much detail, but so we do it is pixel level, so it's not like just tiles and then the tiles has a class or no. So it is truly pixel level annotations that the neural network sees. But I'll leave it at that, and we can have a meeting and let's see what your needs are for that question. But yeah, so I'll leave it a little bit mysterious there.
Yeah, sounds good. I think moving away a little bit from sort of the intricacies of the AI, one of the interesting questions here we got in from the audience was asking about if there's any regulatory considerations in this world, and is that something you've even considered as of yet? What's the status of that?
Yeah, so that's a really good question. Of course, there's a lot of regulation for clinical use. So we currently in the U.S. or in the Americas, we are research use only, and there's some organizations are using our research products through their own LDT process. In Europe, we have multiple CE-IVD and IVD approvals and doing IVDR upgrades for those and seeking new, and we have an ongoing FDA process for multiple things, but I don't really have a timeline to share for that. Of course, everybody hopes that it's quick and painless to do, but we all know that these things take time, and they take time for a reason, and we're very happy to work with the relevant regulatory bodies to make sure that all of this is safe and secure. I think that QuantCRC, I think that both me and Dr. Pai have been talking about this for quite a while, and every time we talk, there's another data set that validates that it works on, and I've said at some point we have to believe that this actually works, because we throw the kitchen sink at it and it works really I'm a little bit blown away about the quality and how generalizable it is. So at some point we're going to have approval for this one as well, but currently it's research use only.
Yeah, as Tom mentioned, there's data sets that I haven't shown you that we've applied it to, and clinical trial data sets that we're hoping to apply it to further, and it's always useful to keep validating this in other data sets, and it's interesting we'll see how much the FDA wants if we end up going down that route.
Right. Yeah, I would imagine too, given that all of this is relatively new, it's maybe some uncharted territory and sort of figuring stuff out as we go along. So it's very fascinating, and I'm sure lots of time devoted to navigating the minefield of regulatory and that whole world.
Yeah. So I think that coming back to one of Rich's slides on the black box versus interpretable, there's no mystery in why this works. This is basically just making things more consistent, more measurable, and that's why it gets better. Maybe I shouldn't say this, but maybe one of the reasons that we have such remarkable performance improvement is that we weren't that great before, in doing that. That risk stratification was actually really poor. And that's why I think that right now we have a clearly better system based on the data, and then of course we need to have ASCO and oncologists and everybody else to agree that this is actually true by showing the data in a transparent fashion. But where the results are pretty interpretable, because we can really trace back all of the findings to kind of quantifiable measurements. So there's really not a black box anywhere.
Yeah, and to Tom's point, I think mostly oncologists, and particularly the ones I've talked to, have been pretty excited about getting a single output that provides a little bit more guidance. Right now they're combining a lot of different features together in themselves, and then some people believe in tumor budding, some oncologists don't, and they use tumor grade, and to guide adjuvant chemotherapy. And so getting one output that says low risk, intermediate risk, or high risk is kind of appealing. So.
And I think that from like from the patient journey as well, like you know, if you can believe that you get no extra benefit for the added 3 months of chemo. 3 months of chemo is it's not a picnic. It's like that actually helps patients, and not only that, but I also think that it's like we've had drug shortages and all kinds of problems. So like how to direct like the healthcare dollars to the most effective and you know, and the people who actually need it, because of course if you have no benefit from chemo, you really don't want to volunteer for like having like an extra couple of months of chemo. It's a harsh treatment.
Okay, great, excellent. We're sort of, this is a great discussion. We're just bumping up against time here, so I just wanted to get one quick question in to Dr. Pai just before we wrap up here, and then to any of our audience members, if we didn't get to your question, rest assured we'll be able to follow up with you after the webinar. You sort of touched upon this throughout, Dr. Pai, but maybe if we could just end on a succinct note of why did you choose to use Aiforia instead of the other AI companies out there? You know, maybe we could wrap up with that.
Yeah, you know, being a content expert, or at least I say that, don't like, but I guess I have been practicing GI pathology for quite some time. So, and colon cancer is something that I've been studying. So, the ability to do something myself was appealing and then I had access to all these digitized images, and I actually digitized a lot of them myself as well. But I had access to all these patients with colon cancer, and so the Aiforia platform allowed me, without relying on others to kind of, you know, train the model and actually do all the work. I mean, it actually allowed me to do it almost myself, and it's really easy to use. And you annotate, you hit train, and then you can actually visually see how it performs, and that was really appealing, and it's still appealing to me. I mean, every time I look at it, I get excited, and building these models yourself can be really satisfying. And then seeing how powerful they are, you know, and how much you can apply it to these different cohorts and get results that are impressive, I think further validates how the Aiforia platform is useful.
Okay, great, excellent, thank you. And as I was saying, we have reached our time. We did have some other great questions come in from the audience. If we couldn't attend to them, if you have any further questions, if you're someone who's watching the recording of this webinar and want to get in touch, we've got the contact link up on screen right now for Aiforia. Very simple, head to their website /contact us, and you'll be able to have a chance to get in touch with them, and they will be able to follow up with you after the webinar. I do thank everyone once again for participating today.